Thank you for the introduction. These are my disclosures. And today the primary objective of this lecture is to really highlight new psoriatic disease findings and data that really challenge outdated ideas in hopes that you'll incorporate these new ideas into your psoriasis treatment strategies. And this is really a conceptual lecture rather than a review of any specific trial data per se. First concept, as you know, psoriasis is a complex heterogeneous disease likely caused by multiple genes. And as you can see here in the figure and highlighted by the red boxes, IL-23 and IL-17 are really central to this disease, primarily from the T cells and dendritic cells, leading to increases here in the skin, triggers increases in IL-17 from the skin, the keratinocyte specifically, which sets up this positive feed-forward inflammatory process, which really drives this chronic disease. The reason we know this is the central pathway is that we have very selective biologic agents which block both IL-23, the P19 subunit, as shown here with these three drugs, risankizumab, guselkumab, and tiltrikizumab, or also blockade of IL-17A through secukinumab and ixekizumab, or also the IL-17 receptor with brodalumab. And we've shown that these therapies are highly effective and also very safe. The first outdated concept I want to highlight is this idea that plaque psoriasis leads to the development of psoriatic arthritis and comorbid diseases such as cardiovascular disease over a period of 5 to 10 years. This is an outdated concept for multiple reasons. One, it implies the idea that skin always presents before the rheumatologic or comorbid diseases, and also implies a direct causative relationship. And this has really been replaced with this new concept that patients with psoriasis are susceptible to an inflammation in general, and therefore they may develop skin disease or psoriatic arthritis or also the comorbidities. But we also know that patients with skin disease don't always develop psoriatic arthritis and vice versa. And also patients don't always develop comorbidities. And one interesting finding suggesting that this is more in parallel is this idea that pediatric patients with psoriasis often develop obesity prior to psoriasis, so more than 90% of these patients. So this concept of rather than a linear association, more of a parallel correlation. It also explains why patients with psoriasis likely develop inflammatory bowel disease, which we'll talk about later. The other outdated concept is this idea that effective skin treatment will definitely improve psoriatic arthritis and comorbidities, such as cardiovascular disease. The new concept here is that recent success in treating skin disease hasn't really translated the same way in the skin as it has in the joints as it has in the skin. And this is highlighted in this table here. When we look at the measures of skin improvement versus joint improvement, and also in the figure highlighting what's in the table here, is that with the newer generation medications, we've seen very rapid improvements in the skin, several-fold increases over what we had with the anti-TNF agents. But however, in the joints, we really haven't seen dramatic improvements compared to what we had with first-line agents like the TNF inhibitors. So still a lot to be learned in terms of what's driving psoriasis. So just because something works in the skin doesn't mean it will work for the rheumatologic manifestations. And also in that same line, we know that we can dissociate psoriatic arthritis from the skin disease, meaning patients can be on a particular agent, have rapid improvement of their skin, but worsening of their joints and vice versa. So we may need to tailor therapy, highlighting again that we need to know a lot more about psoriatic arthritis as it's not exactly what's happening in the skin. And then the idea, the same concept here, that very effective skin treatment doesn't necessarily reduce comorbidities. Jill Gelfand's work in the VIP trials have shown this concept that patients who improve in the skin don't necessarily have reductions in biomarkers of cardiovascular disease. The other concept here that's outdated is the idea that IL-23, because it works upstream of IL-17, must be more effective or superior to anti-IL-17 treatments alone. What we know is that the new concept here is that IL-23 blockade and IL-17 blockade with these highly effective targeted agents are very similar in efficacy. This probably highlights the fact that when you block IL-17, either through IL-17 blockade or the receptor blockade, it actually does result in a decrease in IL-23 P19 when we measure it by microarray or RNA sequencing. So this is highlighting the fact that when you block IL-17, you're also blocking IL-23 and vice versa in the skin just because of this feed-forward feedback loop. And also with the trial data that came out recently with bimekizumab blocking IL-17A and F, we've seen some of the highest PASI 100 scores we've ever seen to date. And so again, blocking the receptor here or multiple aspects of IL-17 may be more effective than just blocking IL-23, as there may be other cells that make IL-17 that aren't regulated by IL-23. And also this concept that blockade of IL-17 definitely results in inflammatory bowel disease. The data doesn't support this. We know that psoriasis patients are already at increased risk of inflammatory bowel disease prior to even receiving any IL-17 treatment. So this is an idea we want to move away from. The other outdated concept is this idea that IL-17 receptor inhibition results in suicidal ideation and suicidal behaviors, and that it isn't better than just blocking IL-17A alone. Multiple concepts that sort of change this paradigm. One is that multiple studies have shown no meaningful link between IL-17 inhibition and suicidal ideation and behaviors. Multiple studies that show that this is probably, again, related to psoriasis patients, their increased risk even prior to therapy. And also studies that have shown, this is just one, but there are multiple, which now show that patients who have failed treatment with IL-17A blockade alone, either with secukinumab or ixekizumab, who failed those therapies, and even 4 that failed both, that blockade of the IL-17 receptor with brodalumab is a very highly effective treatment. And you can see here very high rates of PASI 75, and even about half these patients reaching a PASI 90. So this is a very exciting finding to sort of highlight the idea of receptor blockade versus a specific cytokine blockade as being effective. And just a reminder that when you block the IL-17 receptor with brodalumab, you're blocking multiple IL-17 cytokines, including IL-17A, IL-17C, IL-17F, and IL-17E, also known as IL-25. And this blockade may disrupt more of the signals that are contributing to chronic plaque psoriasis, and therefore may be an effective therapy over blockade of just IL-17 alone, and maybe even over blockade of IL-23. This is a medication that I want you to really consider in these patients who have chronic disease that are recalcitrant to other therapies. And I'll go ahead and end there. Thank you.